So what's new in dermatologic surgery? I, like Dr. Albrecht, have been a Mohs surgeon for many, many years, and I do believe that these 30 years of being a Mohs surgeon has really given me the skill set to look at a very new way of using my talents. I really like to do things with my hands. I always have. Even when I was a little girl, I used to sew with my grandmother. So doing these procedure-oriented things comes really as a blessing and very exciting for me every day. I do have some disclosures. I practice on the west coast of Florida in a solo private practice, and I do a number of consultings, but I'm very fair balanced. I try to consult with all the companies. And did you know that the ASDS actually did a consumer survey, and out of over 7,000 patients, 6 out of 10 were actually considering having a cosmetic procedure done? And what's really interesting is if you look at 48% of the patients we treat have only botulinum toxin done. Only 23% actually do both. Now, in my opinion, they go hand in hand. It's like bread and butter. They're a match made in heaven. So what's holding people back? They're concerned it's not worth it. Do they think they're not really ready yet? Oh, they're ready, especially on the west coast of Florida, where the average age in my town is 65. Are they worried they won't look natural or they will look unnatural? I think that's the key. They can afford it, they need it, but we have scared them because the way we have practiced and the things we've done to some people over time, especially even people of notoriety or people on television, that they look unnatural. So first and foremost, I think that's very, very important to always undertreat, treat slowly. I tell patients Rome wasn't built in a day. We can take this one at a time. We always also, whether I'm doing Mohs surgery or I'm injecting a product into someone's face, I think it's important to have a clean procedure and use an antiseptic. We know in the literature there's been a great deal about chlorhexidine, which irritates the eyes, it's ototoxic. So looking for new antiseptic agents I think has been very important. There's a new one called hypochlorous acid, and it actually kills everything, fungus, virus, bacteria, within 30 seconds of contact, and it's just coming to the market. There's also Technicare, which is chloroxylenol, which has been on the market for some time, and I find that that's an excellent one because it doesn't irritate the eyes and the ears. The benzalkonium, that has been on the market a long time as well, and again, is fairly inexpensive and doesn't irritate, doesn't smell, not like betadine that's messy and kind of leaves its trail of where it's been. Scar prevention. I've actually recently read and researched the literature about applying a silicone scar product right at the time of excision. And it forms a nice occlusive barrier. I've been using Aquaphor, but since I've reviewed and seen that there's some very good data to support that using one of these silicone products in the OR right when you've sutured your wound can just amazingly improve the wound healing around the sutures at the time. Now this is an exciting little tool. This is a new tool for injecting botulinum toxin. It's actually a syringe developed by the TSK company, which I discovered in Paris in January. You can actually dial in and in a metered control fashion deliver 0.5, half a unit, 1 unit, or 2 units. And even though my hand has been injecting botulinum toxin almost 20 years, I can tell you that it really gives you a sense of control that you don't have with other syringes. It also comes with a 33 and 35 gauge needle, which honestly, you barely feel. It's new, painless, invisible needle. And so when you do this, listen to this. It clicks.
Okay, eyebrows up. Relax.
Tells
okay,
you exactly that metered dose. The important thing to remember here is that don't inject a contracted muscle, but do have the patient animate so that you can see where the muscle strength is. You don't want to just inject botulinum toxin with a grid pattern across without looking at the muscle. Here she came back just for a little tune-up, and I've dialed it down to the half unit so I can treat that little comma in a very controlled fashion. Now, another thing I want to share with you is what I came up with called the point of maximum rejuvenation. You know, the fewer percutaneous sticks you make when you're injecting anything, whether it's local anesthetic or whether it's soft tissue augmentation, the less risk of bruising and intravascular injection. So if you look at this, you can actually treat the antemeral cheek, the zygoma, the piriform fossa, and the marionette from one little magic point. This is what I call the point of maximum rejuvenation. Like the cardiologists say, the point of maximum auscultation, this is my idea for a point of maximum rejuvenation.
So what we want to do is determine the point of maximum rejuvenation, where I can really get the most bang for my buck from this injection, from one single point. If I put on the surface of the skin, I know I want to reach this far, so in order to get,
so that's a 25 gauge, 1.5 inch cannula.
Here. But then in order to go south, I can turn from this point and go here and reach the whole pre-jowl region and the marionette. Then I can also come from this one point and go all the way out to the zygomatic arch. Now this patient actually has beautiful zygomas, so we really need to focus just on the medial face with the anterior.
Okay, look at that. Not a bruise, not a single bruise, all from one point of injection. I would encourage you to use cannulas and think about that particular technique. Now let's switch gears and talk about a suture lifting, where you can actually put a 5-0 vicryl suture and re-drape the skin. It has a polyl lactic acid cone on it, and because of that, over the next 6 months, it actually stimulates the collagenesis, and the improvement continues over time.
Now we begin this procedure by marking our entry and exit points. So if you see, you're provided with this little ruler, and the ruler shows you that the sutures are provided to us either 8 cones, 4 on each side, 12 cones, 6 on each side, or 16 cones. As the cones get increased, there's a slightly larger area in between. Mostly I like to start and determine where I want my exit. Look at this, you can see the vector here. So this is our vector lifting. This is exactly what we want to achieve. Not this, because see how this pulls? You want to just simply reposition this tissue in this fashion. So I'm going to choose 1, 2, 3 suture placements here. And I'm going to start, I like to have my exit point at about 4.5 centimeters from the entry point. So if this is 4.5 centimeters, that is going to be an exit point. And then this is an entry point, and this is an exit point.
Okay, I'm going to skip
So this
forward.
is how the InstaLift product is provided to you. You actually need to refrigerate it. And in order to handle the product carefully, it comes refrigerated in ice, and then when you receive it, you put it in the refrigerator. Now, if you open this little box, this is how it comes. You open this, and inside is a sterile package, and in each one of these packages are 2 sutures. This I'm choosing today is the 8. As I told you, that is my workhorse suture that I choose. It also comes 12 and 16. The patient has been prepped with Technicare, which is chloroxylenol. I like chloroxylenol because it doesn't irritate the eyes or ears, and we find that it's a very excellent prep, doesn't cause any contact dermatitis. It's not like betadine, it's not messy. So we've done our marking, we've anesthetized our entry point and our exit point. The next step is we're going to take an 18 gauge needle, and this 18 gauge needle is going to allow us an entry point for the 23 gauge needle that's attached to the 5-0 vicryl suture. So turn just a bit. This is how I learned. Pinch for pink. This pink 18 gauge needle, I'm just going to pinch the skin and make a little entry point. Now when I do this, it's very important, I've learned, that you need to stretch the skin just a bit. Because it's easy to get the 5-0 vicryl suture through this entry point, but if you don't stretch this skin just a bit at your entry point, you all right? No pain?
No pain.
Excellent. Okay, good.
No pain. I love it when they say no pain.
If you don't stretch the skin just a bit, the cones can be difficult to pop in. So another little ouch there. No pain at all. So we're going to push there just a little bit, stretching the skin. Just a bit. Now you can choose to make all 6 entry points at once. We're going to make all 3. We've learned that this also makes the procedure faster because you don't need to keep picking up the 18 gauge needle and putting it down each time. So I make all 3 entry points at once. Okay, very good.
Okay, so look at this. This is how she looked immediately post-treatment. The little dimpling will go away. Sometimes there's a little bit just at the entry point. And then she gets continued improvement due to the stimulation by the polylactic acid. And patients have been, I've been doing this procedure for almost 1.5 years, and I can tell you if you have good patient selection, they've been extremely happy, and it's an excellent new tool in our toolbox. Now again, switching gears, what else is new out there? PRP. So PRP, I think for hair loss, I would like to say is somewhat debatable in the literature. We know exactly what the plasma-rich protein is. When you platelet-rich protein, when you draw off the blood, you spin it down, you take it. And the question is, do these growth factors stimulate hair growth? If you look in the literature, here's an article from last year saying it doesn't work in the Journal of Derm Surgery. And here's an article that says it does work. So I do think it's still somewhat out there. We don't know. The debate is still going. But here were some pictures I found. And this is by using microneedling technique and microneedling in the platelet-rich plasma. Look at this. I mean, if this actually could work consistently, I think that we will have people lined up from here to China. Now, again, I'd like to go here. I have to tell you, I have not personally done this, but it is in our literature, and it's what's new in derm surgery, and that is approaching the female vaginal rejuvenation. We know that plastic surgeons have seen a real rise in labioplasty. We have seen good literature articles looking at genitalia rejuvenation with different tools. These are all the devices. There are lots to choose from to look at for that. I can tell you that I'm not sure exactly how you bring up this topic. I'm used to treating the face, but many of our colleagues are actually finding lots of women who want this procedure done. We can see that it does improve vulvar tightening. And then one of our colleagues actually in Brazil, Dr. Doris Hexel, published using hyaluronic acid. So the question is, do you just want these lips filled, or do you want your other lips filled? The question is yours. I'm just telling you, we need to know what's out there. The OBGYN doctors do not seem to be embracing this, not even the plastic surgeons so much, but many of our dermatologic surgery colleagues are seeing that this fits quite nicely with us. So I think that you can tighten and you can fill a variety of areas. And I will tell you, the good news is we have so many fun things to enhance our surgical toolbox. And I, for one, after 35 years, can't wait to go back to the office to work. So thank you very much. I appreciate being included.